اوكي
احنا ريكوردينج دلوقتي.
اتفضلي يا دكتوره مي، اتفضلي يا حضرتك.
بسم الله الرحمن الرحيم. احنا طبعا النهارده هنتكلم على Membranous Nephropathy, a clinical pathological approach. وبيسعدنا جدا جدا وجود الدكتور احمد القريعي معانا. سعداء بوجودك يا احمد دايما، ويعني دايما محاضراتك
ربنا يخليك
بتبقى
سمي.
فعلا بتدخل جوانا على طول يعني. فان شاء الله
الله
نسمع
يخلي حضرتك.
محاضرة شيقة النهارده. So we are going to speak about the membranous nephropathy. This is very important because we confront this GN type of GN frequently in Egypt. I think it's the most common together with the FSGS. And so we need to know more about its clinical pathologic approach. So please go ahead, Ahmed. تفضل.
شكرا جزيلا دكتور مي، ربنا يخلي حضرتك. بسم الله والحمد لله والصلاه والسلام على رسول الله صلى الله عليه وسلم، واشهد ان لا اله الا الله وحده لا شريك له واشهد ان محمدا عبد الله ورسوله. I'm delighted to be again presenting with the ESNT Professor Hussein Shaish, Allah yarhamu, Academy. And the last time we've gone through the FSGS, me and Wissam, and it was planned as well to be today together or tonight together, me and Wissam, but unfortunately she had some circumstances. That's why she was not able, although I had some of her slides already on my deck, and I hope that I can cover a part from the pathological aspect as well. Thanks for Professor Mai for the nice introduction, and Professor Yasser for letting me going through this very common and critical and maybe a little bit perplexing topic. So let's start going into membranous nephropathy, and we'll try to have it as a clinical pathological approach. This was one of Wissam's slide when she early on showed the history of membranous nephropathy, or what was termed as membranous glomerulonephritis, and this was introduced like the 8th decade, and it was considered as an entity by David Jones. After him, the name of John Stain or Silverstein in the late 50s of the last century. And then the immunofluorescence started to show the immunoglobulin deposits with Mellors later showed the location of the deposits to be mainly in the membrane and in a subepithelial pattern, as we all know. What we through this is going to the pathogenesis, the pathology, the clinical picture, and lately the management guidelines of the KDIGO, which was just released. First, regarding the epidemiology of membranous nephropathy, as Professor May just mentioned, it's very common. Actually, it may be the most common cause of nephrotic syndrome in white, non-diabetic adults. And I have to say that even in diabetics whom are biopsied for suspicion of other alternative etiology for glomerular disorder, membranous nephropathy is #1 diagnosis in those patients. We had recently a series of 690 some patients who were diabetics, and they were biopsied, and the first cause or the first pathological diagnosis among these patients was the membranous nephropathy as well, primary membranous nephropathy, I mean. Saying the incidence of membranous nephropathy is 1 in 100,000 per year, and the plateau are associated membranous nephropathy is typically more common in males, although the thrombocytopenia and the NEL1 associated membranous nephropathy may have less male predominance. So these might be not more common in female, but maybe equal in male and female. It affects individuals of all ages, with the mean age of diagnosis between 50 and 60. And as we'll go through the lecture, we'll find that age is one of the main determinant factors to think about the etiology of membranous nephropathy, whether this is a primary or secondary. In pediatrics, primary membranous nephropathy is quite rare, and this is very important. We don't tend to diagnose primary membranous nephropathy in pediatric age group. Secondary forms such as those associated with hepatitis B infection or lupus should always be considered. Although in very young children, maybe in infants, the SEMA3B or cationic bovine serum albumin-associated membranous nephropathy should also be considered. And these are subtypes of the primary membranous nephropathy, as we're going to see. Maybe these were the earliest diagnosis of the genetic form of membranous nephropathy. In total, 30% of the patient with nephrotic syndrome in adults are secondary to membranous nephropathy. So this is an important issue. As you know, in adults, FSGS almost comprise 35% nephrotic syndrome, and 30% are secondary to membranous nephropathy, and maybe another 15 to 20% are secondary to minimal change disease, adult minimal change disease, and then the rest is divided among other etiologies. Among these, 80% of any membranous nephropathy is primary or idiopathic that have no cause, and 20% are usually secondary to other etiologies. So a patient with membranous nephropathy, this is a KDIGO statement in the latest guidelines. Patients with membranous nephropathy should be evaluated for associated conditions, regardless of whether anti-phospholipase A2 receptor antibody or antithrombocytokine antibody are present or absent, and I've added an exclamation mark here actually. Why I've added an exclamation mark? Because when we go through the rest of the guidelines, we'll find that you can rely on the anti-phospholipase A2 receptor antibody to diagnose more or less an idiopathic type or anti-plateau associated membranous nephropathy. So there is a sort of conflict here, but we'll try to solve this through the lecture. So that's to say, 80% of patients with membranous nephropathy are primary, and the 20% are secondary, and you have to screen for these secondary causes, even if you have an anti-phospholipase A2 receptor antibody positive in our situation so far. And the screening should be based on the age of the patient. If you're looking for malignancy screening, definitely you'll go to do an ultrasound. For the kidney, you will do a virology. The most common one is hepatitis B. Also, although hepatitis C can cause membranous nephropathy, although the most common is to have a mesangial-proliferative or a membranoproliferative pattern, and you should take a full history looking for systemic diseases. Thyroiditis like Hashimoto's can be associated, and a full physical examination to look for symptoms or signs of collagenic disorders or autoimmune disease. You would do an anti-nuclear antibodies, and you would take a drug history, specifically called dipenicillamine, captopril, and others. And sarcoidosis is another cause. You should not forget about that. So let's go through. Actually, it's not typically a hereditary disease in the Mendelian terms of hereditary, but there is a growing evidence that there is a strong genetic component. And like most of autoimmune diseases, there is an association with the HLA, specifically the class 2D locus on chromosome 6, and the DQA1 and the phospholipase A2R1 which are located on chromosome 6 and 2, respectively, both alleles are risk alleles, and they increases the likelihood of having membranous nephropathy by 11-fold if you have those risk alleles, and maybe it's up to 80-fold if you have a homozygous type of both alleles. And this was a very seminal study identifying the risk of the DQA1 and the phospholipase A2 R1 alleles in idiopathic membranous nephropathy, and it shows clearly that if you have here the all SNPs tested, you would have much higher rise of the incidence, whereas if you excluded the MHC, the major histocompatibility SNPs, it's much lower, but again, the null distribution is almost there. So there is an increase of having a risk of developing this membranous nephropathy if you have those alleles. And as we've just mentioned, you can have it like 80-fold higher if you have a homozygous for the lead risk alleles. So this is not actually a typical genetic disease, but it is a genetic risk for having the disease, as if the patient should have a genetic susceptibility and then a second hit would trigger the disease, and it's unlikely that the immune reaction is triggered by changing the antigen sequence or conformation. It's rather like a post-translational modification. So it's a form of epigenetics with preset genetic predisposition and a environmental factor later on in life. Now come to a very important point. Actually, this table is a very nice collective table for the etiologies or the association. I wouldn't say etiologies only, etiologies and or the list of antibodies that are associated with primary membranous or idiopathic membranous nephropathy are growing, like the phospholipase A2 receptor, which comprise almost 70% of these, the thrombocytopenia, which is almost 15%, and the neural growth-like factor 1 or NEL1 associated, and the SEMA3B associated, and still the uncharacterized other antibodies. In secondary, as we've mentioned before, autoimmune diseases like lupus, mixed connective tissue, and this includes, again, another types of antibodies like the exotosin 1 and exotosin 2 associated, which are almost have a high association with the lupus in particular, Sjogren and Hashimoto's, sarcoidosis, dermatitis herpetiformis, and other infection like in hepatitis B, C, malaria, the secondary or congenital syphilis and leprosy. Drugs like non-steroidal, although nowadays we identify non-steroidal as causing minimal change, but it still causes as well membranous nephropathy. The gold salts not being in use for a time, but they've started to reappear in medical practice. Penicillamine, mercury, and this cationic bovine serum albumin in the infant formulas is very important because actually it has a clue for the initial identification of the membranous nephropathy as an autoimmune disease related to food, as we will see later. And malignancy, more common, of course, as solid organ carcinomas like lung, breast cancer, colon, and kidney, non-Hodgkin lymphoma, leukemia, and this might be associated with the thrombosin being expression in the tumor itself. That's why it's not associated only with primary or idiopathic nephropathy. The autoimmune membranous nephropathy is an antenatal autoimmune form with anti-nucleoendopeptidase antibody, and this was the first antibody to be diagnosed in membranous nephropathy, attacking the podocyte, as we will see in the pathophysiology later. And one of the alloimmune membranous nephropathy is the de novo kidney allograft recipient, and in graft versus host disease for bone marrow transplant patients. And that's why primary membranous nephropathy is a very nice experimental model for organ-specific autoimmune disease. It is an autoimmune disorder, but it is not systemic autoimmune. It's rather an organ-specific autoimmune disease. And that's why it's a good point to start for personalized medicine. And by the way, mentioning this, membranous nephropathy is considered in a way as one of the monoclonal gammopathies of renal significance in some forms of membranous nephropathy. And why is this? Of course, in the idiopathic form, like the anti-PLA2R associated one. And why is this? Because it is an antibody mediated, secreted from some sort of a monoclone of the plasma cells that secretes specifically this antibody. And as we'll come to see, it's almost always an IgG4 subtype. So for this reason, it was considered by some as a type of monoclonal gammopathies of renal significance. This table shows the antibodies that we've just mentioned, the PLA2R, the thrombocytidine, and the NEL1, the SEMA3B, and the protocadherin, and as well the NECAM, the extosin 1 and 2, and all these antibodies have been localized in brain glycoprotein, most of them, and there are evidence to be expressed by podocyte, specifically in the phospholipase A2 receptor and the thrombocytidine, and they are present in the epithelial deposits. And this is very important because it is not only an association, it might be involved in the pathogenesis of the antigen-antibody complex. And they are circulating antibodies. That's why you can detect them in the serum, not only in the tissues. And the predominant subclass deposit is IgG4 with the PLA2R and the thrombocytidine, while it's an IgG1 almost in the NEL1, and in the extosin is an IgG1, and this is another important point because we will go through that subtypes of IgG might be helpful in distinguishing primary from secondary membranous nephropathies. And here are the distribution of the antibodies. In the most, it is the phospholipase A2 receptor antibody, and then it's almost like compromising like 70% from the primary subtype. And then the thrombocytidine is like 5% or so. The SEMA3B is another 5%, and the NEL is a third 5%, and the uncharacterized maybe another 20% or so. The extosin 1 and 2 is usually with the collagenic subtype, and this is usually the lupus, most of the cases, and the other secondaries, like in malignancy, they overlap with the thrombocytidine and the NEL1 as well, and the alloimmune hasn't got a specific antibody. This neutral endopeptidase actually is the first to be isolated as an antibody against the podocytes, and actually it's an antigen in the podocyte that have been attacked by an antibody, and it occurs when the mother MME is negative and the fetus MME is positive negative as derived from the parent, from the father. In this situation, there would be an alloimmunization and the neutral endopeptidase would be on the placental surface. And then with the third trimester and the formation of the embryonic kidney and the starting to have these anti-neutral endopeptidase IgG1 crossing the placental membrane and going to the neonatal kidney. And this, or I mean the fetal kidney. And this usually comprising a complement pathway activation, which is usually a classical pathway. And in the classical pathway of the complement, we have to remember that we will find almost always the C1q and the C4d, as we will see later, as opposed to the Mannose pathway or the alternative pathway. This food proteins is a putative triggering agent for a variety of autoimmune disease, and in the GIT, and this is well understood. But having this in a membranous glomerulonephritis or a membranous nephropathy, the idiopathic form, is a breakthrough actually. Some patient had a high titer of anti-bovine serum albumin antibodies, and they are deposited in the glomeruli in the absence even of a PLA2R. A subset of those patients with membranous nephropathy are caused by immunization against an exogenous food antigen. So there's a question, can elimination of such type of bovine serum albumin or some protein in the food help in the management or the desensitization of those patients? It's a big question that have not been answered yet. These are the targeted antigens in the kidney, the endogenous antigen. The neutral endopeptidase was the first one that was described, and the membranous nephropathy was described after that. And then the first human antigen is the endogenous neutral endopeptidase. The mother become immunized from the during the pregnancy, and the antibodies transferred to the fetus through the placenta, as we've mentioned. And then they started to discover the anti-PLAR antibodies back in 2009. And it's, as we mentioned, it's 70% there in idiopathic membranous nephropathy. It's mainly IgG4 with a smaller component of IgG1. There is a genetic background, as we've mentioned. If you're homozygous for HLA-DQ-A1 and on chromosome 6 and PLA2R1 on chromosome 2, you would have like 80% fold risk of having these membranous nephropathy. And it can be detected both in serum and in the biopsy. And this is an integral part in the management, detecting anti-phospholipase A2 receptor antibody in the tissues if you do a biopsy and in the serum of the patient. And as you'll find, the initial management and the follow-up and even the recurrence is based on the titer of these levels and of the antibody, and we'll see when we go through, inshallah. I hope you're following and the sound and the is okay.
Fine, yes. Go ahead, Ahmed.
Okay. Okay. So this is a schematic presentation of the pathology that we're going to go through now. It's an immune complex disease caused by subepithelial deposits. The lesion is an apparent thickening of the glomerular basement membrane, which does not appear early on in the disease course. That's to say, early on, you might do a biopsy for a patient and you might misdiagnose that as a minimal change because of the absence of the severity of the basement membrane thickening. But eventually, with time, it should appear, and the immune deposits are usually IgG, and the subtype, as we said, will be according to its primary or secondary, and there is usually a complement activation. That's why we'll find the complement component again in the glomeruli, and this again differs a bit between the primary and secondary, as we will see. And this what happens. The autoantibodies, as you can see here, are formed against a protein that might be the causative agent, and then it crosses through the endothelium and it goes to the membrane, where in the membrane it's found the target and it is attached. And now we have an antigen antibody complex that is just here, which is subepithelial. That's why the term subepithelial dense deposit is an important term in the diagnosis of primary or membranous nephropathy in general, but again, there would be some differences. So we'll try on the few coming slides to differentiate between primary and secondary, because it all rests on differentiating primary from secondary membranous nephropathy to plan your treatment protocol. So we'll try to find out clues through the biopsy. And this is the deposits that occurs with the antibody formation. Again, this is the podocyte, and this is the subepithelial part. And the thickening of the glomerular basement membrane by these deposits start to occur. And with this thickening, the matrix of the basement membrane actually starts to spike between the deposits, and maybe at a later phase, it starts to surround the deposits in toto. So there are stages of membranous nephropathy, as we will see again, and these stages are only based on EM. You cannot stage the 4 stages of membranous nephropathy except by the EM. So the clinical presentation of the disease is a nephrotic syndrome, as we all know. Proteinuria usually more than 3.5 grams per day, with a serum albumin of less than 3.5 grams per day, and it's present in 2/3 of patients at the presentation, and it can be severe, and the severity does implicate the prognosis. The other third are asymptomatic, and usually the proteinuria is less than nephrotic range. And in most patients, the GFR is normal, and the urinary sediment is bland sediment. There is no hematuria, although microscopic hematuria without cause definitely can be there in less than 25% of patients. Hypertension is not common, but it can occur in less than 20%. Thromboembolic events is important issue, and maybe treatment will be planned, as we'll see, based on this statement. It can occur in 8% of cases. 8%, nearly 10%, yani 1 in every 10 patients, 1 in 10 would have a thromboembolic event, and these 8% or 10%, 1/3 of them are in the renal vein. And just to mention, renal vein thrombosis does not need to have classical triad of loin pain and hematuria and worsening nephrotic syndrome with heavy proteinuria. You don't need to have this triad to suspect renal vein thrombosis. When it's there, the suspicion is very high, but you don't need to have them. You can have a subclinically apparent renal vein thrombosis, and it can manifest only by deterioration of the renal function or deterioration of the proteinuria level, or even asymptomatic, but you should always have a high index of suspicion for DVT in general and renal vein thrombosis in particular in cases of membranous nephropathy, especially so if the serum albumin of the patient is below 2.2 or 2 gram per deciliter in some texts. This lipidemia is very common in membranous nephropathy as much as it's common in the minimal change disease. It's not that common in focal segmental, but it is common in membranous, and it's associated with marked increase in the MI and coronary deaths. And this is another important issue in the clinical presentation. Membranous nephropathy, although rare, but it can present by crescentic subtype. And the trick here is it's a crescentic in a nephrotic patient, not in a nephrotic patient. So people usually wouldn't suspect an RBGN in a patient with nephrotic syndrome, but it can occur in membranous nephropathy, specifically if there is a high level of proteinuria and there is additional hematuria and rapidly declining GFR. And the absence of anti-neutrophil cytoplasmic antibody, the ANCA, and the anti-GPM antibody is classical for those patients. So you wouldn't have an ANCA or anti-GPM. You would have only a diagnosis of membranous nephropathy with a rapid deterioration of kidney function, with no hematuria usually, or no nephrotic syndrome. You would have a microscopic hematuria definitely, and you would have a crescentic subtype, which would need an aggressive therapy. When we go to the complication, we should be aware about the complication of the disease and of the treatment, as we'll go to treatment later. Of course, the patient's well-being is much affected in the chronic nephrotic syndrome with the tiredness, edema, dyspnea, dehydration, thrombosis, infections, and later on maybe the renal failure, diuretics, the hypokalemia, the metabolic acidosis, the hypomagnesemia, the metabolic alkalosis, of course, and the ototoxicity and the muscle aches and others. Of course, the steroids and all the side effects of steroids, cyclophosphamide and the anemia, the leukocytopenia and the gonadal failure and the infertility, the hair losses, and with the calcineurin, the famous side effects of diabetes and nephrotoxicity and gingival hyperplasia and so on, and the infections maybe with the fungal infection and the hypogammaglobulinemia with the rituximab. So you should be aware about the disease and the treatment complications, side effects. So moving to diagnosing a patient with a membranous nephropathy. When you need to diagnose a patient with a membranous nephropathy, first you need to diagnose that he is a nephrotic syndrome. Second, you need to diagnose that this nephrotic syndrome is caused by membranous nephropathy. Third, you need to diagnose whether this is a primary
الصوت يا أحمد؟ الصوت مش موجود دلوقتي يا أحمد. معتصم؟
ايوه مع حضرتك يا دكتوره مي، هو فعلا الصوت مش موجود. انا هحاول
طب
اتواصل مع
نوقف
الدكتوره.
الريكوردينج على بال ما نشوف ايه.
تمام.
بالظبط.
تمام.
Okay, go ahead.
Okay. So you're just mentioning that evaluation of the patient or starting to diagnose the patient. We have primary to diagnose that he is in a nephrotic syndrome.
صوت بيقطع.
And then syndrome and biopsy and all around we can go through. معايا دكتورة مي سامعين؟
سامعين بس الصوت بيقطع ساعات.
ألو؟
انا مش عارفه اذا كان ممكن نحسن الكونكشن احسن من كده.
طيب. ألو؟
ايوه.
كده أحسن؟
اوكي. كمل.
طيب, okay. So we were just saying that we would diagnose a nephrotic syndrome, then we would diagnose a membranous nephropathy, then we would diagnose whether it's primary or secondary, and if it's secondary, we have to go through the potential etiologies of the secondary. And that's why we do the PLAR, the phospholipase A2 receptor. And if it's negative, you can do the thrombospondine as well. And then you can go through the rest of investigation, whether the virology, the markers of the autoimmune disorders like lupus, and maybe the tumor markers or the malignancy workup, including a colonoscopy, an upper GI endoscopy. Maybe you would do even a CT scan for the lung and the bronchoscope. You can do a workup for hematological malignancy, including bone marrow. And this would be based upon the specific situation of the patient and the age of the patient and the family history and the presence of concomitant or comorbid situation. Do not forget to go through the sarcoidosis by simple chest X-ray. Maybe you do a testing for ACE, ACE level, although it's not so much conclusive. Anti-thyroid antibody like anti-TPO and anti-thyroglobulin, and the history for drug exposure. And specifically for the IgG4 related disorders in a patient with a nephrotic syndrome, with abdominal pain and suspected to have pancreatitis, with tubulointerstitial nephritis and sialadenitis, you can think about IgG4 disease, because this might be a milder form of secondary causes that can respond only to steroids, and you don't need to go through heavy immunosuppression like in primary membranous nephropathy. Some infections like malaria and schistosoma and maybe secondary or congenital syphilis can cause as well membranous nephropathy. So you need to be actually as much as you can trying to find out the clues in the patient that can tell you about what potential secondary etiology. It's a very tedious, time and money consuming to diagnose a secondary cause for membranous nephropathy. And after all, it's only 20% of the cases. So you need to try to find out whether the patient is primary membranous or not beforehand. That's why the rely on the phospholipase A2 receptor antibody was very important to consider this point. But this is not a complete story. When you go to the histopathology of a patient with membranous nephropathy, definitely the kidney biopsy is the standard for the diagnosis. And in the kidney biopsy, you need to have all the sets of the tools. You need to have the light microscopy, the immunofluorescence, as well as the electron microscopy. And as we will see, there are value for each one of these. On the light microscopy, there are early stages which might be even misleading, and you would think that it is a minimal change. At a later stage, the spikes and the pinholes started to appear, specifically with the Jones stain or the silver methanamine stain, and with the periodic acid shift stain as well. There is a little bit of proliferative feature, And if you find the proliferative feature to be of paramount activity, you would go for typically a secondary etiology. And this is a very important clue. So let's try to find out the clues in the histopathology to differentiate primary from secondary. One from the early clues is to find some mesangial proliferation or endocapillary proliferation. This is usually associated with secondary rather than primary membranous nephropathy. Crescentic pattern, although very rare, but when it is there, it's usually after primary, not secondary membranous nephropathy. When we go for the immunofluorescence or the immunohistochemistry, you would have usually the granular staining of IgG and C3, kappa and lambda, and the antiplar if you stain for the antiphospholipase A2 receptor in the capillary wall. And this would be in the primary membranous nephropathy. You would add for this the C4D as well. The C4D that we use in the transplant rejection, in the antibody-mediated rejection, is a very good clue for primary membranous nephropathy as well. And if you subtype in the histopathology for the IgG subtypes in the primary, you would find that it is usually IgG4 with small amount of IgG1. Lately, on the electron microscopy, or lastly on the electron microscopy, you would find the numerous electron dense deposit that's classically subepithelial in the basement membrane with extensive food processes. And there is usually absence of any dense deposits in the mesangial areas in the primary membranous nephropathy. These are some of the pictographs of primary membranous nephropathy. Here you can find with the silver methanamine stain diffuse thickening of all the capillary. You know what they call it? They call it handsome standing out capillary profiles, because you can see that all capillaries, due to the rigid wall, are open up. They are not collapsed because the rigid wall of the capillaries. Of course, it's more apparent here. And you can even appreciate the granularity in the membrane in some of these area, specifically here, for example, which are somewhat after the spikes. And this is the immunofluorescence, very nicely delineating the membrane with no starry sky appearance of the mesangial area. It's just in the membrane. And of course, you cannot tell what type of antibody here unless you've been told whether this could be an IgG, could be an IgG4 subtype, could be a C3 or a C4D or whatever. And now you come to the electron microscopy and you can see the dense deposits, these darker gray areas within the basement membrane. Of course, this is the epithelial side, and this is the podocyte with actually loss of the podocyte process, food process, and effacement, and some podocyte affection, of course, very evident. And these are the subepithelial deposits just beneath the podocyte surface. With more progression, you can see the deposits, and here some spikes appears in between the deposits, and then the deposits started to be surrounded in toto by the matrix of the basement membrane. And you can see that there is some integration between the deposits and the basement membrane itself, so that it might start to disappear, or would it be some sort of resolution. And these are the stages of the membranous nephropathy pathologically based on the electron microscopy. First, there are sparse, small deposits without thickening of the GPM. And early on, this might be by the light microscopy misdiagnosed as minimal change. Then there is a more extensive subepithelial deposits with the spikes of the basement membrane in between these deposits. And of course, this would cause thickening of the glomerular basement membrane on the light microscopy. Then as in stage 2, but the deposits are completely surrounded by the basement membrane, so that it would be an intramembranous deposit rather than a subepithelial form. Then incorporation of the deposit in the GPM, which is irregularly thickened, and the GPM now become irregularly thickened, and this is a burned out disease. Again, some of the periodic acid chef here, and you can see the basement membrane thick stain, and you can see the pinholes in the membrane and the spiky nature. And the EM with the deposits here, you can see the deposits here, this darker gray area, and the immunofluorescence of the basement membrane, staining of the basement membrane. As we've mentioned, the early stages in the light microscopy, there is no visible changes, and you might this might be misled for a minimal change, the pinpoint hole, and then the spike starts to appear. And these are another few examples for different stages. Rigid capillaries by the fusionophilic deposits, and then the glomeruli here have a diffusely thickened wall. Of course, you can appreciate the wall is much more thickened, and here even is more thickened with the H&E stain. And even if you look with the Masson trichrome, you can still appreciate the thickened wall. Again, with silver stain spiking, and then the immunofluorescence, you can see the IgG, often IgG4 in primary form, variable amount of C3, and granular capillary wall phospholipase A2 receptor. And this can be performed on a formalin-fixed pronase digested biopsy section. That's to say, it can be done by immunohistochemistry or by immunofluorescence as we go on. And this is a granular capillary loop staining for IgG in nephropathy. And this is granular peripheral capillary wall staining for IgG, and of course for kappa and lambda. If you can have this just by being told from the operator, and this suggests primary membranous nephropathy as well. And here, granular capillary wall staining again for IgG, but not IgG4 in this situation, and that case was a case of lupus. And this is the subclasses of IgG with the different types of membranous nephropathy. In idiopathic or primary, it's mainly IgG4. Mainly IgG4 with a little of IgG1. In lupus, it's mainly IgG1 and IgG2 as well. In sometimes it's an IgG3. In neoplasia, it's again IgG1 with some IgG2. That's why you can a little bit discriminate between these, but unfortunately, this is not always reproducible. With the EM, very evident subepithelial dense deposits, and this is very clear. And the picture here gives the spiky nature on the silver stain. And this is subepithelial dense deposits in idiopathic membranous nephropathy. These are another subepithelial deposits in lupus, but you can see that the morphology is a little bit different. Of course, this would need a very talented nephropathologist to see the differences, but they can tell that you can suspect this or that. And these now are intramembranous deposits. You can see that the deposits are surrounded by the basement membrane all around. It's not only subepithelial as here, it is intramembranous deposits. So can we try to differentiate primary from secondary membranous nephropathy? Yes, there are some findings that can help. If you have IgG1, IgG3, if you have a C1q or extosin 1, extosin 2, if you have a mesangial and subendothelial deposits, along with the subepithelial deposits, if you have cellular proliferation in the glomeruli and endothelial or tubulo-reticular inclusion, these are criteria for secondary membranous nephropathy. So again, if it is IgG4, if you have a C3 and C4D, if you have, instead of this, antiplar, if you don't have any mesangial deposit or any subendothelial deposits and no mesangial or endocapillary proliferation, this is usually a primary membranous nephropathy. So actually, we can differentiate a little bit between primary and secondary by histopathological finding. What is the story of the C4D? It's simple. It's a classical pathway activation, and the classical pathway activation, as you all know, starts by C1q that works on C4, and the C4 is split into C4b and C4a, the C4a, and the C4b would go on and complete the pathway of the C3 and C5 and C3a, C5a is the anaphylatoxins, and you have at the end the membrane attack complex, the C5b9. But here, a byproduct of this C4b is the C4d. And this C4d would go directly and it precipitates in the membrane of the glomeruli, of the capillary wall of the glomerulus, and you can stain for it in the glomerular basement membrane, and it gives you a clue about the classical pathway activation, which occurs in the primary membranous nephropathy. Getting to this point, do we need to biopsy all patients with membranous nephropathy to prove that they are primary, not secondary, or secondary, not primary? Well, this is a big issue, to biopsy or not to biopsy. And we have to be very meticulous with the words here. In patients with positive anti-PLA2R antibodies, preserved renal function, second point, no evidence of secondary causes. That's to say you have to do some screening as well. Kidney biopsy did not provide any considerable information leading to changes in management. Histologic lesions and stages of membranous nephropathy, except for tubulointerstitial fibrosis, have a poor correlation with the prognosis and the treatment response. So why the hustle? Here, staining for phospholipase 2 receptor, A2 receptor, can diagnose PLA2R associated membranous nephropathy in patient with negative serum phospholipase A2 receptor. That's to say, you might have the antibody against the PLA2R negative in the serum and positive in the tissues. And you can have it positive in the serum and positive in the tissues. And you can have it positive in the serum and negative in the tissues. And we will go through these different scenarios later on with the treatment and the outcome. This might occur if serum samples are collected when the patient is in remission, or maybe falsely negative early in the disease course owing to what is called the sink phenomena. That's to say the kidney work as a sink or a sponge that absorbs the antibodies from the circulation, so it is not there in the circulation. It's all precipitated in the tissues. So it's a puzzle. Let's look at this graph. This is the antiplur in the serum, and this is the antiplur in the tissues. And here is the early onset where the patient is usually missed, not yet presenting. And in this period, the symptoms, as you know, in nephrotic syndrome are usually insidious. And in this period, the kidney absorbs the antibody. It's not yet in the serum. So if the patient presented early due to earlier discovery of the proteinuria or whatever, usually the antiplur might be negative in the serum. But if you had a biopsy and if you stain for the antiplur, you would have it positive here. Then the clinical presentation started to appear, and the detectable serum antiplur start to be there, and then it plateau, and you will come to the level of the antiphospholipase receptor as well. There is a level, and the level is of usefulness in determining the treatment plan and even in the choice of the treatment agent. And in all these situations, you have it positive both in serum and in the tissues in most of the cases. And then with the disease resolution period, it starts to disappear from the serum, whereas it is still present in the tissues. And you can see that the proteinuria usually more or less follows the antiplur in the serum, but with a little bit of a lag. This very nice schematic graphs shows the expected finding throughout the course. Early on, you would find it positive in the tissues, not in the serum. During the course of the disease, you would find it both in the serum and the tissues. And with the recovery, again, you would find it still negative in the serum and still positive in the kidney tissue. This Kidney International publication almost 3 years back was a very nice one, and it proves many points that we need to analyze it very meticulously, actually, because it would answer some of the unanswered question about the antiphospholipase A2 receptor. They started by selecting 1,362 patients to having a PLAR test by both immune fluorescence assay and ELISA. So 2 methodologies, and this is serum testing. They had 838 unique patients, and out of these 838 patients, 143 were positive by both immunofluorescence assay and ELISA. So now we are left with 143 patients. Out of these 143 patients, 97 with positive PLA2R serology, native kidney biopsy, and negative workup for secondary diseases. So we have 3 conditions. They are positive for the phospholipase A2 receptor, they had a biopsy already done, and they have negative workup for secondary. That's to say, they did a workup though the patient were PLA2R positive. So what happened with the rest? The rest were 46 patients. 7 of them were transplanted, so they were excluded. 4 patients, they had no biopsies, they were excluded, and we're left with 35 patients, and they were proven to have secondary etiologies. although they were anti-PLAR positive both by immunofluorescence and ELISA. So this is the first point. You can have up to 1/3 of the patient positive for secondary etiology in spite of having antiphospholipase A2 receptor antibody positive. So you cannot rule out secondary etiologies only based on positive antiphospholipase. What they did is they assessed the renal function and reviewed the biopsy of those patients. And they classified the patient into two categories. Those 97 patients, they classified them into those with a GFR more than 60 milliliter per minute, which is a normal renal function. And these were 60 patients. And the other 37 patients, they had a lower renal function, less than 60 milliliter per minute. And they tried to answer the question, was the biopsy necessary? When the ELISA was more than 2 relative units per ml, and this is the unit of measuring the antiphospholipase A2 receptor in the serum, when it is more than 2 relative units per ml, and the immunofluorescence assay was positive in those patients that have a preserved renal function and that have no secondary etiologies, renal biopsy did not have any added value for the management. So they concluded that if you have 3 criteria, if you have a positive PLA2 receptor and antibodies, and if you have excluded secondary etiologies, and if you have a normal renal function, no need to do biopsy for those patients with primary membranous nephropathy. Again, this is a classification of the patient from the start, and those the 838, the unique one, and they were tested by both ELISA and immunofluorescence, and 11 were excluded, and we left with 132, and those 132, 35 were found to have secondary, and this is the part of the graph that I want to stress. 35 patients positive for anti-PLA2R, both by ELISA and immunofluorescence, and they were proved to be of secondary membranous etiology. 11 of them were autoimmune disorders, Sjogren, rheumatoid, and lupus. 2 of them had lung cancer, 4 of them had prostate cancer, and 9 had other types of malignancy. So collectively, 15 patients had malignancy, and 3 of them were after non-steroidals, and 6 had some sort of paraproteinemia. So it's 1/3 of the whole sum positive for the anti-PLAR are secondary, not primary. With those who are pure primary, no secondary etiology after screening, positive anti-PLAR, and intact GFR, there were no added value of the biopsy. But with lower GFR, they did the biopsy, or they find that the biopsy had an added value because the amount of interstitial fibrosis is determining of the prognosis of the kidney. So that's why this was the conclusion. If you suspect a membranous nephropathy, do a PLA2R by immunofluorescence. If the immunofluorescence is positive, perform an ELISA. This is more specific and it gives you a value. If the value of the ELISA test more than 2 relative units per ml, diagnose membranous nephropathy. If you excluded the secondary etiologies and you have a normal renal function, you can avoid doing the biopsy. If the ELISA is less than 2 relative units per ml, or if it is initially negative by immunofluorescence, you would perform a renal biopsy and you would stain for the PLA2 in the tissues, and if it is negative, stain as well for the thrombospondine in the tissues. Again, an alternative approach. Do ELISA at the start and look at the degree of the positivity of the PLA2R. If it is more than 20 relative unit, diagnose MN and do exclusion of secondary causes. And if renal function is okay, you don't need to do biopsy. But if it is more than 2 but less than 20, do immunofluorescence. If the immunofluorescence assay is positive and it is between 2 and 20, go to the first pathway. If it is negative, but the ELISA is positive between 2 and 20, or if it is initially negative by ELISA less than 2, so perform a biopsy as well directly. Now we are approaching to come to the conclusion of what to do with our patient after all these points. First, you have to categorize your patients into risk stratification. Your patient is either falling at the low risk group, and this would mean that you would mostly observe, or a moderate risk group, and this again is more or less a closer observation with some chances of having the less aggressive therapy forms. If it is high risk group, you would start therapy immediately, or it's a very high risk group, you would start aggressive therapy immediately. So let's look for the criteria to classify the patient for high or low or moderate risk. For the low risk group, first, it's a normal EGFR. Second, proteinuria is less than 3.5 grams per day. And thirdly, albumin is more than 3 grams per deciliter. I will stop with the albumin here. You know, in Egypt, most of the labs, if not all, measure the albumin by what we call promocresol green. And the promocresol green methodology, as opposed to the promocresol purple, does overestimate albumin in the serum, and this was mentioned in particular in the KDIGO guidelines actually, that you need to measure the albumin in our nephrotic disease patients by promocresol purple or by immunoassay. If you going to use the monocresol green, which is in most of our labs, unfortunately, you have to correct. Like you do correction for calcium, you do correction for the anion gap by albumin and so on, you correct. You correct by subtracting 0.55 gram per deciliter from the value, and this is a big number. I mean, if you have a back from the lab, the value as 3.5, and it is tested by promocresol green, the actual value would be 2.95 gram per deciliter. And as you can see, this transfer you from a low risk to moderate risk, for example. So this is an important point to be mentioned. Or if you have a normal GFR with a proteinuria less than 3.5 gram per day and it already decreased more than 50% after 6 months of conservative therapy with ACE or ARB. If you have a response in the proteinuria on just RAS blockers, this is a good omen for that the patient is low risk. But you have to have this response significant. Decrease, let's say if it's 4 grams, it goes down to 2 grams over a 6-month period. With the moderate risk, the proteinuria is more than 3.5 and there is no decrease by the 50% over 6 months, but not fulfilling the high risk. What about the high risk? You're having declining renal function. You're having proteinuria of more than 8 grams for more than 6 months. Or you're having a proteinuria more than 3.5 grams and not decreasing over 6 months of time in spite of conservative therapy with RAS blocker, plus one of these, albumin less than 2.5 grams, phospholipase A2 receptor more than 50 relative unit. Remember that we were measuring by ELISA 22 and less than 2, more than 20, between 2 and 20, and less than 2. This is 50, it's 2.5, the upper limit of diagnosing a primary membranous with exclusion of the secondary etiologies. So this is a very high. And if you have a urinary alpha-1 microglobulin of more than 40 microgram per minute, or urinary IgG more than 1 microgram per minute, or urinary beta-2 microglobulin more than 250 milligram per day, or a selectivity index of more than 0.2. And the very high risk is a life-threatening nephrotic syndrome with pleural effusion that causes dyspnea, with repeated infection, with severe oozing from the skin and ascites and pericardial effusion, and so on, or a rapid deterioration of the kidney function, which is not otherwise explained. That's to say, not due to pre-renal, not due to non-steroidal associated or nephrotoxicity or whatever. So again, this risk stratification is very important because we have to act upon. And this is another way of risk stratification. It is the same finding, but it gives you here some remarks. In the low risk, the non-nephrotic progression preceded by development of overt nephrotic syndrome, and serum albumin should be measured by promocresol purple or immunoassay. So you usually wouldn't have progression from a non-nephrotic to a poor situation or a high-risk patient unless the patient would pass through a nephrotic range. That's why when the patient is a less than 3.5 gram and the albumin is more than 3 gram per deciliter with the promocresol purple or the immunoassay, you are safe to conserve your patient and just monitor. Again, it's unlikely to progress. And there is a high likelihood of remission. And this figure is a golden figure that we're always moving around, that in a year time, usually there is a spontaneous remission of 40%. But this is for those patients, not for every patient, not for high risk, not for very high risk. For the moderate risk and the low risk, or those patients, they have a likelihood chance of a spontaneous remission. In the low risk, it's even more than 40%, might reach 60 to 70%. In the moderate risk, which is proteinuria more than 4 grams per day for more than 6 months, and it decreases by less than 50%, but it does not fulfill the high-risk criteria. That's to say, there is no renal impairment, there is no aggressive proteinuria more than 80 grams, and the PLAR is not more than 50, and the other urinary proteins like the beta-2 microglobulin or the alpha-1 microglobulin or the urinary immunoglobulin G are not in the levels. So you would leave this patient as well for the spontaneous remission, which might occur in almost half of the patients. But if it is in the high risk, you have to go for active treatment. And of course, the very high risk, you would treat the patient in full support with supportive and immunosuppressive agents. Again, all patients with primary membranous nephropathy and proteinuria should receive the supportive care. Immunosuppressive therapy should be restricted to the patient who are considered at high or very high risk. And the immunosuppressive therapy is not required in patients with membranous nephropathy with a proteinuria less than 3.5 and the serum albumin more than 3 grams per deciliter by the promocresol purple or the immunometric assay, and the GFR is more than 60 milliliter per minute. So 3 criteria: proteinuria less than 3.5, serum albumin more than 3 grams per deciliter, and by the standardized way, and the GFR is more than 60, do not treat by immunosuppression. Immunosuppressive therapy is not required if nephrotic syndrome with normal GFR, unless another risk factor, which is the AKI or infection or thromboembolic event, are occurring, as we've mentioned with the other, or a high level of anti-PLAR, more than 50 relative unit per ml, or a high level of alpha-1 microglobulin or beta-2 microglobulin or IgG. Okay, so let's go for the treatment, what to do. When you have one risk factor for progression, you should start either rituximab or Ponticelli regime, which is a cyclophosphamide alternating with glucocorticoids for 6 months, or CNI, which could be plus or minus steroids. So we have 3 options actually, and we will linger around these 3 options. When you have a membranous nephropathy, if it's low risk, wait and see. If it's moderate risk, wait and see, or alternatively, you can use rituximab or calcineurin. High risk, rituximab or Ponticelli regime or calcineurin plus rituximab. Very high risk, it's Ponticelli regime from the start. So this is the scheme, and we're going to go into the details. Again, if it's in a membranous nephropathy, low risk, wait and see. We have to put these points in consideration because many patients are being treated unnecessarily. Moderate risk, it's almost wait and see again. You can wait for 6 months before adding a treatment. High risk, rituximab, cyclophosphamide, which is Ponticelli plus glucocorticoids alternate month, and calcineurin inhibitor. Very high risk, you only have a Ponticelli regime, whether the modified or the regular Ponticelli or the Dutch Ponticelli. And these are the Ponticelli regime. The classical one is to give the patient steroids in month 1, 3, and 5. As we all know, it's 1 gram per day, IV methylprednisolone in the first 3 days from month 1, 3, and 5. And then the rest of the 27 days, the patient would take oral prednisolone with a 0.5 milligram per kilogram per day for the rest of the 27 days. And on the alternate months, month 2, 4, and 6, the patient would take the chlorampicil 0.2 milligram per kilogram per day for the 30 days. The modified Ponticelli is to use cyclophosphamide in a dose of 2. Usually we use the 2, not the 2.5 milligram per kilogram per day instead of the chlorampicil. So it's only changing the alkylating agent to use cyclophosphamide instead of chlorampicil. The Dutch regimen, they use it in a little bit different way. The steroids, again, 135 with methylprednisolone, again for 3 days, and followed by oral prednisolone with the higher dose of 0.5 to 1 milligram per kilogram per day for 6 months. So you would give it for 6 months, then taper, plus oral cyclophosphamide in a lower dose, 1.5 to 2 milligram per kilogram per day for 12 months. So it's a longer duration, higher cumulative cyclophosphamide dose, which is of course more toxic for the gonads and for the bone marrow, because as you know, you all know that the cyclophosphamide depends on the cumulative exposure. Calcineurin inhibitors, you use tacrolimus in 0.05 to 0.075 milligram per kilogram per day for 12 months with a trough level between 5 and 7, very similar to ours in the maintenance phase of transplant. Then taper over 6 to 12 months, plus or minus low dose prednisolone. So you give it for a year and you taper over another year, so it's a long duration of treatment actually. If you give cyclosporin, we usually use a 4 milligram per kg, and you would target a trough of 120 to 200, and you again give it for a year and taper it over another 6 months to 1 year. For the rituximab, there are many regimes for the rituximab. The simple is to give it in a single dose, and you measure the CD20 count. You don't give a second dose unless you have a rising CD20, which might occur after a month or after 3 months or after sometimes 6 months. And the dose would be 375 milligram per meter square. So an average person would usually take like 600 to 700 milligram. That's to say a vial of 500 and 1 or 2 vial of 100 milligram. You can give it in 375 milligram per meter square every week for 4 weeks, and that's 4 doses. Or you can give it only 2 doses at 1 week interval, or you can give it like day 1 and day 15 and repeat it again after 6 months. So again 4 doses, but 2 doses initially and 2 doses after 6 months. And this is the proposed algorithm for the management. You start with the supportive therapy. You measure the antiplar and the thrombospondine. And if they are negative, do the biopsy. And if in the biopsy they are positive, do the antibody levels and clinical monitor every month or bi-monthly. That's to say, if the patient's stable, the antibody are to be repeated, because as we said, it might be initially negative because of the sink theory in the kidney and then started to be positive. Then you move on, keep on every month or bi-monthly measuring the antibody level. If the serum antiplar turned to be positive with a high level, more than 50, as we mentioned, or increasing proteinuria or decreasing GFR, you would move to the treatment. If it is positive from the start, or the biopsy is negative and it is positive in the serum, you would measure again monthly or every month and go for the risk evaluation that we've mentioned. If there is decreasing antibody, you would do nothing, just monitor every 3 to 6 months. If normal renal function, persistent nephrotic syndrome, and low or moderate antiplar level, that's to say between 2 and 20, so start immunosuppression, consider rituximab as a first line, then CNI. Ponticelli is not here because of the high toxicity of the alkylating agent. If it's a high-risk feature, severe nephrotic, or more than 50 relative unit of antiplar, or GFR is decreasing, start immunosuppression, consider Ponticelli regime as a first line. Alternative would be the rituximab. And this is how to approach the patient after 6 months. Now you give the patient already one of these 3 arms of treatment. After 6 months, you repeat the PLA2R receptor antibody. If it is absent, do nothing, do nothing, do nothing. Whether you gave him calcineurin, or you gave him rituximab, or you gave him Ponticelli, only with the calcineurin, because as you know, we give it for a year. So taper slowly. If it is present and you have given the patient rituximab, continue another cycle of rituximab. If you've given the patient cyclophosphamide and glucocorticoids, this is the Ponticelli, stop the Ponticelli, do not repeat it, but give rituximab because of the toxicity of the Ponticelli. If you given the patient calcineurin, taper the calcineurin, add rituximab, or give one course of Ponticelli. If it is present but decreased to low levels, less than 50 relative unit, if rituximab continue, if Ponticelli, stop Ponticelli and just carefully watch. If calcineurin, continue and taper over another 6 months. This study shown the value of phospholipase A receptor antibody in the outcome of the patients. It's a longitudinal study that have shown the relation between the proteinuria and the PLA2 receptor level by the IgG. And as you can see, the response is somewhat differs between the three treatment protocols, the CNI, the alkylating agent, and the rituximab. It is in the reduction of proteinuria, having the rituximab the best of them, and the alkylating agent is the least of them, whereas the CNI in the middle. But if you go for the level of the anti-PLAR, they are almost all the same. And the study showed no specific difference, except for that the high level of the anti-PLAR is the one that can show value by the multivariate analysis for achieving remission of proteinuria when you can control or not. And of course, using the immunosuppression, definitely. And this is the practice point for the KDIGO guidelines, the algorithm for treatment if patient with minimal nephropathy with initial relapse after therapy. You give the initial treatment by rituximab. They relapsed, repeat rituximab. Calcineurin inhibitor, prednisolone, relapsed, give rituximab, or give calcineurin and rituximab. Ponticelli, relapsed, give another Ponticelli with rituximab or calcineurin with rituximab. And this is the approach for the treatment of resistant nephrotic syndrome. If you give initial treatment with rituximab, stable GFR, go for a calcineurin inhibitor. No response, go for Ponticelli. Resistant to rituximab and Ponticelli, there is nothing to be done. Consult expert center, which is, nothing more to be done. If the eGFR is decreasing, so don't use calcineurin. This is an important point. You cannot use calcineurin with the lower GFR because it would add to the nephrotoxicity. So you'd go directly for the Ponticelli. If you're starting with a CNI with a stable GFR, so go for rituximab. No response, go for Ponticelli. If the eGFR is decreasing, so do not use, go directly for the cyclophosphamide. Do not use rituximab. If you're starting with the Ponticelli, again with GFR stable, code is rituximab. If failed, repeat the Ponticelli. If GFR is decreasing, don't go for the rituximab and repeat the Ponticelli directly. So it's a bit of complicated with resistant cases, and after all, at the end, you can have a little to be done. Last, how about the kidney transplant recipient with membranous nephropathy? For the pre-transplant evaluation, if the patient is associated with PLA2 receptor antibody, known with associated PLA2 receptor, measure the level. Unknown, and he is membranous nephropathy, again measure the level, because it might be firstly negative, then turns to be positive. If it is negative, retrieve native kidney biopsy and stain for PLA2 receptor antigen. If antibodies have disappeared, low risk of recurrence, this is 10%. If there is still antibodies, there is a medium risk of recurrence. If it is measurable in the blood in the first place, there is a high risk of recurrence up to 50%. So a patient with membranous nephropathy who is going to perform a kidney transplant should have the Pla2 receptor antibody measured in the blood first. If it is positive, wait. If it is negative, look at the biopsy. Retrieve the native biopsy and stain again for the Pla2 receptor and look whether it is positive or negative. And according to this, if it is positive, so there is a low risk of recurrence. If it is negative, and the patient was negative initially, so it's primary membranous, negative in the blood, negative in the tissue, there is a medium risk of recurrence of the membranous nephropathy. Although having negative and negative, and this is a puzzle. And you should discuss the recurrence rate and discuss that it might be higher after living-related donor transplantation. But as we mentioned in the FSGS beforely, the benefit of living donor donation overwhelm or overweight the possible harm of the disease recurrence. So although the recurrence as nephrotic syndrome is higher, but the overall outcome for living donation is better. You should monitor the proteinuria, of course, and you should monitor if it is increasing to 1 gram, do a biopsy, and you should monitor the Pla2 receptor. If it is increasing, so the likelihood of recurrence is higher, so do a biopsy again. If it is decreasing, so the likelihood of recurrence is decreasing, so do not perform a biopsy unless clinically indicated. Of course, the treatment is a supportive treatment by the RAS and who ensure the adherence to the cyclosporin, to the CNIs. And if the proteinuria is less than 1 gram, just evaluation every 3 months. If it's more than 1 gram, add rituximab to your regimen. This is the last thing, which is the anticoagulation. As we've mentioned that 8% of primary membranous would have a DVT, 30% of these 8% would have it in the renal vein. If the serum albumin is less than 20 gram, again by the promocresol purple, and I would, which is 2 gram per deciliter. I would remind you that this equals to 2.55 by the promocresol green that is used in most of the Egyptian labs, unfortunately, if not all. And or it's 2.5 by the promocresol green, as we mentioned. If it is yes, this is a high venous risk of thromboembolic events. If it is no, is the serum albumin less than 3 gram per deciliter or 3.2 by the promocresol green? If it is yes, again, estimate arterial thromboembolic event risk. So if it is between 2 and 3 or 2.5 and 3.2 here by our labs, so you still have to look for the arterial thromboembolic risk. If it is no, nothing to be done. No aspirin from the start. No aspirin. If you have a high risk, you would add aspirin. If you have a low risk, you would add no aspirin. And this can be estimated like in the CHA2DS2-VASc score that we use, the arterial risk, thromboembolic risk that we use with our regular patients. If it is high venous thromboembolic events, high risk, assess the bleeding risk by the HAS-BLED. So you can use the CHA2DS2-VASc and the HAS-BLED scores, for example. If it is high risk for bleeding, so give aspirin. If it is low risk for bleeding and he is in these values of the albumin, you start by anticoagulation, whether by warfarin or low molecular weight heparin plus aspirin. And as you can see here, it was not mentioned the new oral anticoagulant to have a role in this situation. And this is the maybe the final slide, the clinical and pathological feature to distinguish between recurrence from de novo membranous nephropathy in patient, whether it is a recurrent or de novo. The de novo is much less. The pathogenesis here is antiplar. Here is not fully known in the de novo. The clinical presentation is similar to the primary. Here can be asymptomatic. The diagnosis is kidney biopsy and the PLAR level. Typically, the PLAR is not positive and there is staining of the deposits negative as well. And IgG1 is the predominant, not the IgG4, as if it is secondary, not primary. And the treatment here is monitoring of the antiplar, transplant immunosuppression, and rituximab to be considered or to be given if worsening of the disease. But here, there is no clear history progression. So rituximab or cyclophosphamide can be considered if there is rapid decline of the kidney function. And this was my last slide, and I hope that I was not too much lengthy in the presentation, but it is, after all, a very, needy topic. Thank you for your attention.
Thank you very much, Ahmed. It was really very informative and very illuminating. And so the few questions, because you just mentioned everything actually. So one of those questions is when you use rituximab, do you use steroids with it?
Rituximab, actually, no. The three arms are cyclophosphamide or Ponticelli regime with the alternate steroids, the calcineurin plus or minus steroids, though we can use it without steroids as well. But the rituximab, usually, no, we don't use steroids. It's rituximab without steroids.
Because the many use steroids with the rituximab, or they start rituximab and start reducing steroids after the rituximab. So maybe that's. But you don't have to use steroids with the rituximab. Yes.
Yeah, there is no in the guidelines. There is no use of steroids with rituximab.
But you use cyclosporin with the rituximab in those patients who are not who are resistant to treatment, for instance.
Yes, according to the line that is going, if they are resistant to cyclosporin initially, you can add rituximab on. If they are resistant to rituximab, you have the option to add cyclosporin or to add Ponticelli regime.
Yes. Okay, very well. So, do we have other questions in the chats? Tacrolimus, Rami? Tacrolimus, Benaya versus
Cyclosporin?
Cyclosporin, yes.
Well, actually, tacrolimus might be a better option, although it's not very common in our use. But it is a good option, and there have been some literature trying to compare tacrolimus to cyclosporin with no very strong conclusive results. But it looks that tacrolimus can be helpful, and if you try to use tacrolimus after cyclosporin when cyclosporin failed.
Well, we have this question. Why arterial thromboembolism mentioned with membranous nephropathy?
Yes.
The question is, why is it mentioned with membranous nephropathy?
Yes. Actually, as we all know, it's there for all nephrotic syndrome. But because maybe in membranous nephropathy, there is a special predilection for both venous and arterial thromboembolism. Of course, the venous being more, and especially with the serum albumin when it is lower more. And the severity of membranous nephropathy, severity of the nephrotic syndrome in membranous nephropathy is usually much more higher than focal segmental, for example.
Yes, yes.
That's
Yeah.
why it's specifically mentioned in particular with membranous nephropathy.
So we have always to remember if we need to use anticoagulation in membranous nephropathy.
Yes.
Another question from Rami Abu Bakr. What is your opinion about MMF in primary membranous, especially in the low EGFR?
Well, actually, I haven't
Is there a
come
place
through.
for MMF?
Yeah, I haven't come through an evidence for its use in membranous nephropathy instead of. I mean, it would be an option if you don't have a rituximab and the patient had a lower GFR, that you cannot use a calcineurin.
Yes, that's
yes,
right.
and you don't have the luxury to, or you're afraid from using the Ponticelli regime. But whether or not this would give you a good response, because it is not there in the guidelines for the KDIGO in the last update. So it might be not a good option.
You mentioned
because
that
if you remember when we mentioned the FSGS, it was mentioned that you can use it.
Exactly.
In
but
the
this
FSGS.
Membranous, it's not mentioned.
But in the membranous, it's not mentioned at all.
About the patients with for transplant that had primary membranous, you mentioned that we use we test for the antibodies in the serum, and then we take a biopsy. But at that time you could have a shrunken kidneys.
not take a biopsy. They just say that you have to retrieve the native biopsy.
Oh yes. Okay.
And try to look after whether it had the antibodies in or not, but not to take a new one.
Yes, that's right. Makes sense. We have a question from Professor Manal. Manal, ازيك? How are you, Dr. Manal الديب? Manal, would you like to say your question about the ACTH use in membranous nephropathy?
I haven't come through it actually. The ACTH again have been mentioned in focal segmental.
In resistant cases in the membranous.
And the trials again was not promising, and it was not. And of course we have to mention that this is not the regular ACTH that we know. It's the synthetic ACTH, but this was in particular in the FSGS and was not recommended to be used. After all, no added value in most of the cases, but I'm not aware about it in membranous nephropathy.
There is a question here: is if the patient that is potential kidney transplant has a PLAR antibody positive, does this mean that you will have to postpone the surgery, or you can go ahead with the surgery?
In the serum, if it is still positive, and the patient had a high titer, that's to say more than 50 RU per ml, it's wise to postpone the surgery.
Okay. Actually, this
is if it is in a lower titer, let's to say less than 20, you can go, but you have to explain to the patient that the risk of recurrence is significantly higher with the serum level still positive.
Yes, so if it's very high, I would yes, go for postponing the surgery, but it's not very clear how long are you going to postpone the surgery and the operation. It
The
would
repetition
persist to
would be every
high.
3 months at least of the level.
So it's a bit, you know, what level are you going to go on with the transplantation? So it's not very clear actually, but we know that a very high level is very risky. So it's
Yes.
better to avoid in very high levels. So when do you stop immunosuppression, Ahmed? So because I see many nephrologists, they continue with the immunosuppression in the membranous nephropathy patients. So when should you stop the immunosuppression? If say if the patient shows partial response, do you continue with the immunosuppression or you stop it, or what do you do?
Okay. Now, if we said that we have 3 different arms of immunosuppression, either the rituximab alone, or the Ponticelli regime, or the cyclosporin plus or minus steroids. If we go for the rituximab alone, so it's only 4 doses at the maximum. It might be either every 1 week or two doses initially and 2 doses after 6 months. And then you would stop unless you would have a resistant form, so you would shift to a second line. Then if you go for the cyclosporin or the CNI line, you would go for a year on the CNI and taper over another 6 months, maybe to another year. So the patient would take 1 year with the full course, and then over the second year, you would taper gradually the CNI. If we're going for the Ponticelli regime, it's only 6 months and you don't repeat it. And if the patient did not respond initially or relapsed after he responded, you would give rituximab. You don't give another cyclophosphamide or another Ponticelli regimen.
And what about the steroids?
Steroids, if it is with Ponticelli, so it would stop immediately with the Ponticelli. If it is with cyclosporin, so you would taper again over 6 months. But if we use steroids with the cyclosporin, we have to use the least dose. I mean, you would start with the 20 to 30 milligram maximum and taper it rapidly over a couple of months to 3 months to 10 milligram. And you don't continue on with 1 year for 30 or 40 milligram or even 20 milligram while you're giving the CNI, because the mainstay here is the CNI, not the steroids.
Exactly. And would you say that you stop immunosuppression with the GFR of less than 30 or serum creatinine of 3.5 milligram per deciliter? There will be no meaning of continuing the immunosuppression?
Definitely yes.
Yes.
Definitely yes.
When we reach to that stage of kidney function, yes.
After verifying that this is a chronic state, I mean, it's not an acute exacerbation of whatever cause or a pre-renal or whatever. So whenever you are confident with that the GFR is low chronically, and now the GFR is 30 milliliter per minute or less, no need to give more immunosuppression, because eventually the patient would pass into end stage and he would need transplant later on. So keep the cumulative dose of immunosuppression for the next to come.
Maybe you will have to do a biopsy to make sure if this is due to the chronicity of the disease or something that comes up, some like crescent, for instance, or otherwise.
Yes, definitely. We do this a lot in patients with lupus in particular, because sometimes the activity and the change in the pattern of the disease can be there. With membranous nephropathy, if the course is ambiguous a bit, or it's not clear whether this is an acute on top or it's you can do, and the role of rebiopsy in glomerular disease in general is very much undertaken. I mean, there is a lot of situations that we can do a rebiopsy, and one of the most important is to avoid over-immunosuppression to a failing kidney.
Yes. Thank you very much, Ahmed. Really, indeed, we learned a lot from you. And I wonder if anybody wants to ask about anything before we end. Okay, thank you all for your persistence and thank for everybody. Thank you. Bye-bye.
Thank you, Dr. May. أشوفكم على خير. السلام عليكم ورحمة الله.